Coming to our first topic, simulators and robotics in neurosurgery. So before going into this, we have to understand few things. First, what is the definition of a simulator, and what is the commercially available systems that are there, and what are its use cases. So now, if you understand, so before going to an actual surgery, if we can simulate the environment of the surgery so that a person is trained in that environment, that is what a simulator does. So what it will help a person is, it will give a haptic feedback so that the person can monitor how he is performing the surgery, whether he is losing too much blood during the surgery, or he is applying too much force during the surgery, or how much he is resected during the surgery, and what is the appropriateness of clipping during the surgery. So now, coming to the definition, what is computerized neurosurgery simulation device? It is first of all a computerized device. What does it do? It simulates a surgery like environment using a 3D visualization of various surgical scenarios. Now, users are provided with two instruments, arms, and they get a haptic feedback of the that can monitor the movement, the degrees, and pressure. And hence, at the end, what it will give them? It will give them a outcome of the amount of blood loss, amount of extra force that they had to apply, how much they have resected, what is the success of resection, and what is the appropriateness of clipping. It is used as a surgical exercise before jumping into the surgery. Coming to robotic surgery. Robotic surgery is a system that is used as an intraoperative assistance to surgeon, where surgeon sits at a remotely controlled remote location and controls the station and guides the robotic arm. So suppose you are sitting in Delhi and you want to operate on a patient in US. So it's not usually that far. You can also do such that the robot is, you are not in the operating theater with the patient, but you are sitting outside and controlling the robot. Now the robotic arms are used to perform the procedure. Now there are different. Now coming to the next part of the question. So you told what is a simulator and what is a robotic surgery. What are the commercially available neurosurgical simulators? So the commercially available neurosurgical simulators are: one, we have our neurotouch simulator. Now neurotouch simulator is a task specific, pre-developed scenarios are only present in that, for various tumor resection, hemostasis, and using a ultrasonic aspirator, etc. So if a first year resident comes in for surgery and he has to learn on how to perform a neurosurgical procedure without a direct hands-on, he can use a neurotouch simulator, which is based on pre-developed scenarios. Now we have something called as a surgical planner, or SRP, or surgical navigation advanced platform, or SNAP. So now this SNAP, what it does is, it integrates the pre-op MRI and CT for patient specific practice. So now with this, you can actually think, the scenario here is preloaded. Here it is, we upload a pre-op MRI CT for patient specific practice. So now we can also integrate it with navigation system. Other thing is immersive touch simulation system. This is also, it has both. It is pre-developed scenarios. Also, you can upload and CT and MRI for patient-specific practice. The advantage is it has 3D glasses of visualization for better depth perception. You can have a immersive touch simulation system. So three systems. One was a neurotouch simulator, which didn't have, which is just based on pre-developed scenarios. Then you have a surgical planner, or SRP, and then you have a immersive touch simulation system. Then other thing is the neurosurgery robots. So you have different neurosurgery robots. CyberKnife, do not confuse this with the the CyberKnife is a robotic radiosurgery system. It's technically not a robot that is doing the surgery, but it will guide in how the radiations are focused. Okay, so if we use CyberKnife, is just a name of a company. If we use X-rays, it is called as CyberKnife. If we use gamma rays, it's called as gamma knife. So Then other than that, you have our neuroarm. Neuroarm is a image guided surgical robot with MRI compatibility. So in this, we still don't know how effective it is. And then we have our famous rosa. So rosa is successfully used to obtain stereotactic biopsy. After successful calculation of the coordinates, a robotic arm is placed over the desired entry points and the trajectory of the stereotactic biopsy is automated. Now we have to get the robot and place it on the trajectory. That is the main problem with it. See, anyways, docking is done by the assistant who are there in the OR. Now coming to spine assist or Mazor robot. Now this is an amazing software for pedicle screw placement. Basically what you do is you do a neuronavigation, and with that you load the neuronavigation software, and then you tell the software, with Renaissance software you need to tell it where to put the screw. So now coming to the robots, we saw 4 robots. One is Cyberknife, other one was Neuro Arm, other one was Rosa, and you have Spine Assist. Now, what are the use cases? Coming to simulation is required so that residents are trained. So with this, every neurosurgeon has a standardized training across the globe. And also in a specific condition where the tumor is difficult to treat, then we can use this system so that particular people are trained in particular way, and we can also rehearse it, reduces intra-op time and reduces intra-op blood loss and reduces post-op morbidity and mortality. Now coming to robotics. Why do we need robotics? Advantages: smaller incision, more precision, less blood loss, less hospitalization and less post-op pain. And also one important thing is we can also operate remotely, and it can be integrated with AI. The problem is it has high cost and limited degree of freedom and poor judgment. Now coming to robotic surgery versus stereotactic surgery. The types of robots used in neurosciences are: one, you have neurosurgical robots and you have neurorehabilitation robots. Now, neurosurgical robots, you already saw them. They were our ROSA, they were our spine assist. Then, so those are the ones which are used in telesurgery. Now, there are two types. One is a autonomous system where the whole surgery is done by the robot itself, giving a pre-programmed feed. So robot produces autonomous motion by calculating desired position based on AI. So they are the stereotactic robots. So no need of surgeon, robot does the surgery. And coming to the dependent system, where surgeon maintains full control of the system, that is in telesurgery, and surgeon navigates as to where and what the robot should move, like in many oncosurgery procedures. Now there are shared systems. Shared system is where there is combined autonomous plus dependent system, so it can filter out unwanted tremor and hand movements, like robotic arm holding a endoscope. Robotic arm holding endoscope. Now coming to neurorehabilitation robots, there are two types. One is therapeutic robots, other is assistive robots. The therapeutic robots are for compensation of loss of function. So it is like an exoscope that you wear on yourself and you walk. Now coming to assistive robots, mainly what this assistive robot does is it will be for task specific training. In the sense, you have a person with stroke, you need to rehabilitate him. So now how do we rehabilitate him? For that we have one is a end effector type device, where there is mechanical assistance to distal joints, no control of proximal joints. So body weight support from shoulder joint, and you have a programmable foot paddles, treadmill, etc. And other there is exoskeleton type robot, where it is aligned according to anatomic axis of the patient and controls individual joint movements. So in therapeutic robots, it is for a complete loss of function. Suppose if you are using Neuralink software, if you have a complete loss of function, then you are using a therapeutic robot. That is also an exoskeleton. This one is more of a avatar type of robot where you are the one sitting inside and controlling the movement. And the end effector type device is for mechanical assistance to distal joints. Now, coming to the next topic, that is neuromodulation. So, neuromodulation is a way in which we alter the neural activity through targeted delivery of stimulus. It either normalizes or it stimulates or suppresses the neural tissue function. So now physiological neuromodulation. So normally our body has a physiological neuromodulation in which there is upregulation and downregulation of activities because of neurotransmitters. Here we are using electrical signals for neuromodulating. Now, how do you do neuromodulation? One is by direct electrical stimulation. It is invasive, good spatial and temporal selectivity, and converts passively given electric field into a depolarizing action potential. So if you actually think about it, it's like this. So now you give a direct electrical stimulation, like say in a spinal cord stimulation. It gives a real-time feedback of whether the patient is having pain relief or no by doing that particular stimulation. So if he is having pain relief with that, then we stop doing. Then we can continue doing that stimulation, and it can select exactly as to when it can stimulate. Now. So what it is changing is this passively given electric field is changing into a depolarization action potential. Next is transcranial electrical stimulation. It is safe, non-invasive, and reduce spatial resolution. So what it basically means is spatial resolution and temporal resolution. Spatial resolution means you are understanding what are all structures you are stimulating. That is usually possible only when you have an invasive device. So you are putting on that structure and telling this is what it is stimulating. Temporal means with time. So now with this, you can just select a gross area in the cranium and you are stimulating that whole area of cranium, but you are not actually selecting this motor cortex or this neuron is what I am stimulating is not there in there. Now coming to magnetic stimulation. Transcranial magnetic stimulation basically converts magnetic field into small electrical currents, and that results in depolarizing action potentials. It's a safe, non-invasive, high power consumption and needs an external magnetic source. As you know, it will be very poor spatially selective than electrical stimulation. Now coming to thermal neuromodulation. Temperature induces changes in transmembrane flux and can result in depolarizing or hyperpolarizing. Now, this thermal neuromodulation is how we can think of MRFUS. So, where you focus the ultrasound in different places and then you change the temperature. When you change the temperature of a particular area, you can lesion that area with it. Now, ways to apply thermal neuromodulation: direct, rapid, localized heat application. Optically induced thermal neuromodulation. So this optically induced thermal neuromodulation is what is used in optogenetics. And you have, so you are healing by near infrared light and laser light. And then you have microwave RF healing systems where there is intracranially induced nanoparticles are used called neural dust, and they help in healing. Now coming to chemical, you have microfluidics that can be used to change the environment around neurons and changing the transmembrane potential and postsynaptic potentials and induce or suppress action potentials. So first we used electrical signal till now. Now we are using a chemical signal. So what are the different things that we used? We used a magnetic signal, we used an electrical signal, and we used direct electrical signal by applying it on the surface itself. And we are using thermal signal. Now we are using a chemical signal. And last is acoustic or mechanical signal. So this is by using ultrasound waves, non-invasive, safe, and better spatial resolution other than other non-invasive methods, mainly useful in retinal prosthesis. Now coming to this thing called as optogenetics. So what basically optogenetics does is, we found that there are some things called as opsins. So these opsins are things that are found in all the that responds to light. They are the membrane cells that respond to light. Now suppose you have a membrane. If sodium is channel, suppose this codes for sodium channel, whether this opens or closes is based on, it can be opened or closed based on the light that is stimulating this. This is called as a uh, this is called as a opsin. So now with specific light you can either open a channel or close a channel. So you have two types of opsins. One is channel rhodopsin, other one is holorhodopsin. Channel rhodopsin is a stimulating opsin. Holorhodopsin is a inhibitory opsin. To be specific, it is channel rhodopsin 2. Okay, so now, so how do we apply this? Basically, it is used in studying, like now in specific neurons. Now using a viral vector, we can transfer this rhodopsins into the neurons. So when we transfer this rhodopsins into the neurons, we can either excite the cell or inhibit the neuron. So if we excite a particular neuron, what is the result of it? That can be studied by using a different light. Now this is stimulated by blue light and this is by yellow light. So now by using different types of light, we can decide whether we want to stimulate a particular neuron or inhibit a particular neuron. Now coming to application of neuromodulation in development of neural prosthesis. So how will we develop neural prosthesis with neuromodulation? So now a bionic arm is there, or a neuroelectronic system is there, brain computer interfaces are there, cochlear implants are there, brainstem implants are there. All this are developed, all these neural processes are developed by using this different neuromodulation techniques. Now suppose you think about a Neuralink software. So it will study all the impulses from the brain, and then it will use this to transmit to it will convert this into an electrical signal, and now after this the same electrical signal can be applied on the brain to stimulate it and do different works. The next thing is to R&D in neurosciences. Basically, optogenetics is the way to go, and it is mainly used for different neurons do what function. If you stimulate what neuron, what will happen. And last is for therapeutic purposes. So for therapeutic purposes, we have two types of modulation. One is direct electrical invasive modulation, other one is chemical modulation. So now direct electrical invasive modulation is spinal cord stimulation, deep brain stimulation, vagal nerve stimulation, peripheral nerve stimulation, occipital nerve stimulation, hypoglossal nerve stimulation for OSA, posterior tibial stimulation for incontinence, and sacral nerve stimulation for incontinence. And you have chemical modulations, that is for baclofen, intrathecal baclofen pumps for spasticity. And coming to electric modulation but not invasive, that is your TENS. And for neuromodulatory cure by targeting or stimulating innate immune response, we can change for diabetes, obesity, infertility, rheumatoid arthritis, autoimmune diseases. So basically in this, how we are using this is, we can cure a particular disease by like diabetes by triggering a particular immune response.